behalf of Nirupama Health Research Charitable Trust on the webinar, that is Importance of Vestibular Rehabilitation in Physiotherapy by Dr. Preksha Shah ma'am. Ma'am is a APTA from USA, and she's licensed from USA. She's also a certified vestibular rehab therapist from USA. We would like to welcome you, ma'am. And the moderators for this webinar are going to be Dr. Mayank Singh sir, Dr. Rupa Kumari ma'am, and Dr. Manisha Meena. That's me. With this, I would like to conclude and say that a very warm welcome to this webinar, and I would like to request to Preksha Shah ma'am to take over from here. We welcome you, ma'am.
Thank you, Dr. Manisha Meena. Happy World Physiotherapy Day to everyone. Let's start. So our topic today is role of vestibular rehabilitation in physiotherapy, introduction of vestibular rehabilitation in physiotherapy. So it's same like what is the scope of vestibular rehab in physiotherapy, okay? So how many of you are aware with the vestibular rehab? They can just put yes in a chat box so I can see how many you are very well familiar with the vestibular, and who they are new, they can just put no, we are not aware of vestibular rehab. So I'm waiting for your response in the chat box. Yes, yes. Okay. Okay, so many are there who are very well aware with the, good evening, yes, aware with the vestibular rehab. So that's very, very nice. And those who are new, we can definitely get basic idea like what is vestibular rehab. I'll try my best so that you can get to know that what is vestibular rehab. Let's see. Just give me a minute. Okay. So I am a licensed physical therapist in US, and all over I have 11 years of experience as a physiotherapist in total India and US, and I am a certified vestibular rehab therapist. My main population I have treated is geriatric. I don't have much experience with the children, but yeah, I do have colleagues who I have seen they have treated nicely with the pediatric too. Let's see. I'm just having a little issue with my screen sharing.
मयंक जी आप अपना माइक ऑफ कर लीजिए, सेशन स्टार्ट हो गया है।
ओके सर, ओके सर।
Okay, so someone has mentioned that they have learned and heard from the Sullivan, and probably in our physiotherapy college they cover little bit of vestibular like BPPV and all. So in initial days it was mainly BPPV, but it's now vestibular rehab is very vast subject. Now I will tell you where you can follow. So J. Hardman, she is pioneer in vestibular rehab. You can follow her research. Susan Whitney, she is very thorough with her research on vestibular, whether it is for pediatric, whether it is for geriatric, whether it is peripheral vestibular, whether it is central. So you can follow Susan Whitney. You can follow Jeff Walter. If you are very much interested in concussion, you can follow Patricia Hume. She's from Auckland, New Zealand, and she's very thorough. She has so much research in concussion. So you can follow the few pioneer physiotherapists who are very good in vestibular rehab. So I would say Hudman, Suzanne Whitney, Patricia Hume, Jeff Walter. You can Google it and you can find. I am not able to. I'm so sorry, with some technical issues, I'm not able to forward my slide. Okay, so in many years back, it's known that only BPPV physiotherapist has role in BPPV, but now even audiologists, even in Northern America, they have recognized the role of vestibular rehab in physiotherapy. So I know I've been in India and there is not much development in India for vestibular rehab. But if you go to US, if you go to Canada, if you go to UK, if you go to Australia, if you are very thorough with your vestibular thing, it's add on extra points in your resume. They definitely have very, very large scope outside India. And even in India, is just need awareness that we can do it together. Please do not send me. Okay. So we definitely need awareness about that. Now, if we see 5% of population affects with the dizziness and 70% dizziness is related to vestibular impairments. So if we don't have much data for developing countries, but if we take data for developed countries, for example, if we say UK, 5%, so like 3%, 3 million people are affected with dizziness. In that, 2 million people are affected because of vestibular impairment. In concussion, athletes, so many athletes get concussion. If we see the data, usually 3 million athletes get concussion in a year, and in that, 70% are related to vestibular. So, any symptoms you heard, concussion, any symptoms you heard about dizziness or balance issues, it is somewhere around it is related to impairment in the vestibular system. So that is the scope of physiotherapy, vestibular rehab. We feel we are treating patients for balance training. We usually think it's more of proprioception. We are using balance board, we are using wobble board and all. It also challenges the vestibular system. It's not purely proprioception. So unknowingly, we are including vestibular rehab in our day-to-day treatment also, but we are not aware that it is a part of vestibular rehab. So as we go through, you get little bit clear what is vestibular rehab. Okay, what is benefit of VRT, vestibular rehab therapy? Just like other physiotherapy, it is non-invasive. So as long as if we are able to treat the patient, we do not advise for the surgery, right? So if we know of OA patient, if we are able to treat with the therapy, conservative is always better than the surgical, right? Same way, if we are able to treat with vestibular rehab, we do not advise for the surgical procedure. Surgical procedure includes acoustic implant, vestibular implants, just like the cochlear implants. It's cost effective, it's non-invasive, so it's very, very common basic physiotherapy thing that what is the benefit of vestibular rehab. Now, any patient comes with the terminology like dizziness, things are moving. Oscillopsia means everything is jumping around. You feel they are little tilted on one side, the pulsion, the balance is affected. Some patients have visual vertigo. If they see complex visual symptoms, they get the vertigo. If you are very thorough with your vestibular knowledge, if you have your hands-on test, you are able to assess those patients to rule out whether it is vestibular related or whether it is a neurological or orthopedic or musculoskeletal related. So for example, in India, there are so many people who are affected with the dizziness, but because of lack of awareness, we not able to diagnose them. We are not able to treat them. For example, my aunt, she sent me all the reports and she said I was having dizziness and my doctor asked me to do blood reports, checking blood sugar, renal test, liver function test. She has done everything. Her problem doesn't resolve, and after listening symptoms, it was BPPV. So even general physician or neurologist or orthopedics, they are not able to differentiate what is the cause for dizziness, and they are not referring. It's in our hand, like how we convince them and how we get our patient, how we convert patient to our clinic. So if you are very good with your knowledge in your vestibular, you can definitely do that. Now, one thing, vestibular is officially we are able to treat the patient. We do not require any certification. We do not require any license in India to practice as a vestibular therapist. You just need your knowledge, you just need your experience, and you just need your tools. Okay, so if you are very good with your knowledge, you can Google it, you can go on YouTube, you can attend some workshops, gather your knowledge, and you can definitely able to treat the vestibular patients. Now, if we see, usually we can treat vestibular patient in 4 to 6 weeks. In 4 to 6 weeks, you are able to treat them very nicely if it is peripheral vestibular, and if it is BPPV, within 1 or 2 sessions, their problem solved. So it is very easy, and but you just need hands-on, you just need experience with it. Okay. So it's not like you should not worry about like what is vestibular. You should not afraid about it. You just need to make things familiar to you. And once you get used to it, once you start seeing patients, it will comes in your fingertips. Like you are able to treat them very easily. Now it's not like musculoskeletal that you are gonna get the patient every day, hundreds and hundreds of patients every day. Okay, but in your 10 patients, if you get 2 patients of vestibular and if you are able to treat them, it's your achievement, right? So it's nothing wrong in learning and getting used to with the vestibular. It's just like you are getting used to with the cardio, or it's just like you are getting used to with the antenatal and postnatal. Okay. Yeah, who they are very passionate about vestibular and they want to open their vertigo clinic, they want to work with the vertigo clinic. There are so many vertigo clinics in metro cities that runs by neurologists or audiologists, otologists. If you want to work with them, you can go with your advanced training and you can definitely work as a vestibular therapist with them. So these are few familiar terminology you can get to use if any patient says that they are feeling dizzy or they are off balance. It strike your mind that might be somewhere around vestibular is affected, and you need to see them. Okay. Uh, Someone can please mute yourself. How many of you are aware with the vestibular system? Majority of you, right? It's in inner ear and it has connections. We usually deal with 3 things: vestibular ocular reflex, vestibular colic reflex, and vestibular spinal reflex. One second. Can you please mute yourself? Dr. Ria, can you please mute yourself?
It's a request to everybody. Please keep your mics off or muted.
Thank you, Dr. Manisha. Okay, so let's forward with the vestibular system. We usually deal with the three things: vestibular ocular reflex, vestibular colic reflex, and vestibular spinal reflex. Now, what is vestibular ocular reflex? So, the role of the vestibular system is when our head is moving, it fixes our eyes on the target. So, that explains our VOR. It's our eye movement related to our head movement. So we can use this also for test and we can use this as for treatment also. What is vestibular colic reflex? It's a position of head respect to our trunk. So our vestibular system tells our brain that our head is not like this, our head is not like this, it is upright or it is tilted or it is like that. Very, very precisely. Very precisely, this reflex tells our brain that what is the position of our neck. Third thing is vestibulospinal reflex. It is our balance. Now we know the balance we achieve with the harmony of the three things: visual stimuli, proprioception stimuli, and the vestibular stimuli. Our vestibular system, our canals, and our otolith organs, the utricle and saccules, gives the stimulation to the brain, and our brain realize our balance. Now, what happens if our vestibular system is not working? We are still able to achieve our balance with our visual and proprioception, but not 100%, maybe 80 or 90%. And it will increase our cognitive load. It increases our cognitive load and it affects our ability to perform dual tasks or complex tasks because our brain is now concentrating to maintain the balance. So that's I'm not going in detail, but basically as a vestibular therapist, we deal with the three reflexes: VOR, VCR, and VSR. Let's move forward. Okay, so here we can see it's in our inner ear. This is a labyrinth vestibular system comprised of three semicircular canals, utricle and saccule. I'm not going in detail in anatomy and physiology. This is a cochlea. So we do not have much research done on what is the relation of vestibular and cochlea, what is the relation of hearing and balance together. But if one thing is affected, second thing is affected. If hearing loss is there, your balance gets affected. We don't know the connection, but it seems like your music and your dance is together. It's like that. In some patients, in some children, if they have a sensory neural hearing loss, SNHL, if after putting the cochlear implant, their balance also increase. So we don't know the relation, but yes, they are together. But vestibular comprise only with five things: three canals and utricle and speculum. Now there is a question for you. You can just put T or F. Cochlea is a part of labyrinth. It's true or false? Everyone. I'm waiting for your response. Do you feel cochlea is a part of labyrinth or not? True, right. Very nice, very nice. Yes, yes, yes. Thank you so much for your reference. Yes. The total labyrinth comprises of vestibular system and cochlea. Together, it's known as labyrinth. This is just to get you aware with the canals. They arrange at the angles together to measure all the angular neck movement. And the utricle and sacule has a relation with the gravity because of autoconia, and it makes our brain aware our position related to the earth. So that's the, and this is ampulla. It's at the dilated portion over here at the canal, and we are not going in the detail of physiology. Okay, now what are the disorders? Now we know about the vestibular system, right? Only 5 things: three canals and utricle and sacule. And it has periphery part, and it has central connection to the brain in central nervous system. So anything goes wrong here at the peripheral organ or at the central level gives you symptoms of vestibular impairment. Okay, so anything, if any canal is not working, if nerve supply is damaged, if blood supply is damaged, the organ is not working, gives you symptoms for the peripheral vestibular. And if it is affected to the central, it gives you symptoms of the central vestibular disorder. Okay. Physiotherapy has role in both the things. Either it is peripheral, either it is central. So which condition we usually treat as a vestibular rehab therapist? We treat vestibular neuritis. It's a viral infection to the nerve, and because of that, our vestibular gets affected. Usually it is unilateral, and we have very, very good rehab results because we still have intake other things. So we can utilize that to compensate the peripheral loss. So peripheral includes vestibular neuritis, anterior vestibular ischemia, labyrinthitis, Meniere's disease. If Meniere's disease is not progressive, if it is stable, we can definitely work on those patients to get the results. This is I'm talking for unilateral vestibular disorders for peripheral impairments, peripheral involvements. So if you meet any physician, if you meet any ENT, if you meet any audiologist, you can expect it definitely has a role in this kind of patients. If you have any patient for vestibular neuritis, send them to our clinic. If you have any patient for the labyrinthitis, send them to our clinic. That way you can increase your clients for vestibular treatment. And believe me, the results are very, very good. Acoustic neuroma is a third number intracranial tumor, so we can get in more population. The rehab part we can utilize post surgery. Post surgery, what is the residual we can pick from there? We can do gaze stabilization, we can do balance training, and we can treat those patients post surgery. Superior canal dehiscence, same. Post surgery, we can treat those patients too. And bilateral vestibular disorders. So bilateral vestibular disorders usually occurs with the ototoxicity. Like if you have heard, it's very common in Canada or UK because of streptomycin or because of gentamicin or because of cancer treatment, because of medication, because of toxicity. Our laboratory system is very, very delicate. They get the bilateral vestibular disorders. If both the vestibular is affected, total loss, nothing left, we can still try vestibular rehab. We can train them for balance and compensation. Results are not that good, but at least we can get 40 to 50% improvements. In bilateral vestibular, the main symptom you can see is oscillopsia. They feel everything is moving. Their daily life is very much affected, very, very much affected. Even they can't brush because if they see in the mirror, they feel everything is jumping, everything is moving. So yes, if you are very good, you can give it a try for this patient also, bilateral vestibular disorder. If you feel you have tried everything, If you feel it's not gonna help them, then you can recommend them for the vestibular implant. There are, I think, two surgeons in Bombay. They are doing vestibular implant too. So you can Google them and you can refer those patients too. I have seen 26-year young female. She had a oscillopsia, and it's very hard for her to get up, dress up, everything. Even if she walks, she feels everything is moving and everything is jumping. If you can imagine how hard it is for them. Now, if we talk about the vestibular system, it is a sensory organ, okay? We do not call it as a spatial sensory organ. We say our vision, our taste, our hearing, those are spatial sensations. But vestibular is also very special and it is very complex. That's why God has put it inside in the ear so we do not damage it. So it is very complex. Now, if you feel if child do not have vision and if they grow, how hard life it is for him. Or if you are not able to taste anything and if you are eating every day, how hard life it is for you. Same way, if you don't have vestibular system at all, how hard life is gonna be with you. So for those patients, even if we are able to help them little bit, like we do some modifications, we do some handicap arrangements for them, we do so many home rearrangements for them to make their life easy. It comes in our physiotherapy roles, it comes in occupational therapy roles. So we goes hand in hand with vestibular physical and occupational therapy for these kind of patients. So now we are familiar with the peripheral impairments. Now we get familiar with the central impairments. If posterior circulation TIA, you might get the vestibular symptoms. Cerebral degenerative disorders, multiple sclerosis, you might get vestibular. If it is related to vestibular pathways or related to vestibular nuclei, you might get the vestibular symptoms and we can treat them. In peripheral, results are very good. In central, it's not 100%, but we can still achieve 60-70%, depends on case to case. Now, there are some, if neurological conditions, if they are not stable, central conditions, if they are not stable, we do not get good results. But if they are stable, we can definitely indicate them for vestibular rehabilitation or rehab therapy. So that I cover peripheral vestibular related to the vestibular system. Now, what other things we can see? If it is traumatic brain injury and they feel dizziness, they might have BPPV, they might have concussion, they might have anything related to brain injury. We can still treat those patients. Now BPPV. So we get more patient about frozen shoulder or osteoarthritis, right? Same way, we get more patient of BPPV in vestibular rehab. In vestibular rehab, if you get 10 patients, 7 to 8 out of that 10 patients are your BPPV patients. And why it is very good? Because in BPPV, within 3 sittings, we usually get in 1 or 2, but within 3 sittings, they are symptoms free. Some patients are geriatric, like more than 70-75 years, and having dizziness since years and months and all. If you treat them within 2 to 3 days or 2 to 3 sittings, they're gonna love you, right? So BPPV is very common in our scope. We just need here I have seen ENT just recommend them maclazine or some vertigo medicines and send them home and they keep on taking medications. Nobody just even ENT do not assess them for BPPV. They might have very minor BPPV causing their fall, causing their off, making them off balance, making them nauseatic, but they do not evaluate them for BPPV, just prescribe medications. They go home, they take them, get the side effects of medications, but they never get the treatment for that. So it's in our hand that we can make population aware about it and we can treat them. I'm not going in detail what is BPPV, what are the cause of BPPV. Majority of you are aware about BPPV, so I am not going in detail. I do take BPPV in my workshop in detail with all the different canals and all different maneuvers. Each canal has a different test to see which canal is involved, and each canal has different maneuver to do. You can definitely able to do it your own, and with the experience it's very easy. It's not that hard at all. So BPPV is benign paroxysmal positional vertigo caused by the autopia. The crystals comes in your semicircular canals and you get the BPPV. So that is also a scope of VRT in physiotherapy. Okay. So any peripheral involvement, any central vestibular involvement, any BPPV, any traumatic brain injury, we can treat those patients with the vestibular rehab. Concussion. I told you like concussion is very coming up now in athletics. So many places they have accepted the role of physiotherapy in concussion. Many years back, it's just known as the just rest after concussion is advisable, but now they said vestibular rehab is very effective in concussion therapy, in concussion management. In concussion, 70% get the symptoms of dizziness. 50 to 70%. It's the second common symptoms of concussion, dizziness, and may be related to vestibular. So if we treat those symptoms, it might be VOR impairments, it might be nystagmus, it might be visual motion sensitivity, it might be balance issues post concussion, but it falls under the vestibular rehab and we can able to assess that and we are able to treat them. So there is a definite role of VRT in concussion. All the conditions have different tests. All the conditions have different management. If you see peripheral has a different test. If you see central has a different test. If you see concussion, it has its own test. Like we can do worms, we can do brooms, we can do King's Devic. So tests are different for each and every condition, and management is different for each and every condition. So once you get your basic, then you can go your intermediate, and then you can go into your advanced training. And once you start seeing your patient, you can explore yourself. You can start reading the research article. You can start reading the newsletter. You can start reading the journals, and you are able to get that pretty easily. After concussion, cervicogenic dizziness. Yes, we do have a role in cervicogenic dizziness. Many of you have attended my cervicogenic dizziness webinar also, and we do pretty common tests like neck torsion test, neck torsion smooth pursuit test, different tests to rule out that it's a cervicogenic dizziness related to the vestibular origin, and we can do the treatment. We can do VRT in cervicogenic dizziness. Okay, vestibular motion sickness. Now, motion sickness is a collective definition. We might get sickness with so many things, right? We might get sickness with the visual stimuli. We might get sickness with the height. We might get sickness with any sensory mismatch. But if sensory mismatch is from vestibular, like us canal are telling something different, and our otoliths, our utricle and saccular are telling something different. It causing mismatch. It includes your vestibular motion sickness. So for example, my head is like this. Okay, so my semicircular canal is telling that your head is tilted to the left side. But my saccule and my utricle is telling my head is tilted to the right side. My brain gets confused and makes me vestibular sick. 80% population have a physiological sickness, but so many so many population, so many people, if they have any problem with their vestibular system, they might affect and get the vestibular motion sickness. We do have a different test to rule out vestibular motion sickness. We do have different management to treat the vestibular motion sickness, and we can definitely treat those patients with the vestibular rehab therapy. So we have a role in unilateral, in peripheral, in central, in concussion, in cervicogenic dizziness, in vestibular motion sickness. So these are very pretty common basic diagnosis where we can pick up patients, like they can benefit from the vestibular rehab. There are many more for geriatric. There are so many congenital defects which includes the vestibular involvement, but I am not going in detail with that. I'm just giving you the basic idea like where we can utilize the vestibular rehab. So we got little idea where we can utilize them, which equipment we need to test them. Very basic. We need the Snell's chart. We can definitely get that. Tuning fork, we can get that. This is a memory foam pad. Usually you get RX or any spongy memory foam, you can take it for the balance. Goggle for the video nystagmography. We do not need this because we are not doing, we are at that high level. But yes, if you have your own vertigo clinic, if you want to spend money, you can definitely go for video nystagmo goggle. In our clinic where I was working, we were treating even BPPV patients with the video goggle because we are able to see the nystagmus when they are starting, when they are stopping. So we can change the head position and then we can continue. But it's totally up to you. And if you are working in a clinic, vertigo clinic with some physician or ENT, they might have it. So you can utilize that if you are know how to use it. It's very easy how to use it. Okay, so examination, very basic. I'm going. We usually see everything: visual fields, gaze fixation, smooth pursuits, cats, everything. What for newcomers? What I'm saying, very easy to understand. If anything involves without head movement, like your head is static, and you are doing test, that we are checking your central vestibular. And if your head is moving, that you are checking for your peripheral vestibular. So if I say, if I do saccades, here I have slide for the peripheral. So let's go with the peripheral. How to check that the patient has impairment? How to see that peripheral vestibular is affected? We do bunch of tests. For example, for knee, we do bunch of tests, right? For ligament test, this test, other tests we are doing. Same way for vestibular, to rule out they have peripheral, we do bunch of tests. So for peripheral, what we do VOR, vestibulo-ocular reflex. We can do in horizontal, we can do in vertical. So just like this, you keep on moving head and ask to target the, fix the gaze on the target. That is your horizontal VOR, this is your vertical VOR, okay? I'm not going in detail like how to check the test and what is the outcome and all. I'm just making you familiar with the test. Everything is available, or everything you can refer to references. This is a vertical VOR. Okay. Now quiz for you, because I don't want to make it very boring. So dynamic visual acuity test used for central vestibular impairment. It is true or false? How many of you are aware with the dynamic visual acuity test and how we can do it? The test has 100% sensitivity. If test is positive, it means the patient has vestibular impairment. So is it central? The test is for central vestibular or peripheral? Just put true or false. Sorry, the question is like, it's for central vestibular, no question mark. Is it true? Is it for central vestibular? Okay, people are saying true. No. Dynamic visual acuity test is purely for peripheral vestibular impairment. So if your patient is having dizziness or that they have some nystagmus or anything, if you want to differentiate with the peripheral and central, do for dynamic visual acuity. If the test is positive, it's mainly peripheral. And the test is 100% positive if they have bilateral impairment. If they have bilateral, the test is 100% positive. Okay. How we can do the test? See. Okay, so just a minute. So what was the test? How we can do it? I'm just telling you in briefly. I'm not saying any instructions. You can keep the snell's chart at the distance. Ask the patient to read them. Now, if patient is reading without moving head, she is able to read nicely. If you start oscillating head, the eye is not able to focus on the target. Eye is moving because vestibular system is not giving input to the brain. So they are not able to read properly. If they are not able to read more than 4 lines, the difference is more than 4 lines, the test is positive. This indicates the peripheral vestibular loss. You can do it very, very easily. You can use metronome on your mobile to put the beep because oscillation is going to be very high frequency, usually 120 hertz per second. So like 2 cycles per side on 1 second. That way we can oscillate the head. We ask them to read the test. So that's we can do dynamic visual acuity test. So if any patient comes randomly without any reports, they said they have dizziness, they have vertigo, they have balance issue. I usually start with the central or peripheral test. I explain you about the vestibular ocular reflex, dynamic visual acuity reflex. Then we can have saccades. Saccade is for central. Here we are not moving our head. So this is for central. We just ask patient to look from target to target. Okay, so saccade is for central vestibular impairment. Smooth pursuit is also central. We can test conversion. Conversion is also very, very related to the central. And in concussion, I definitely use conversion to check the any vestibular involvement. If you have any concussion patient, I definitely refer you to do the conversion test. So yes, different condition you need to know with the history and pathology and like which test to be precise you want to do it, and you can get the diagnosis. Vision motion sensitivity. So yeah, I told you about the vestibular motion sensitivity, like visual motion sensitivity. If patients are telling that if background moves, if stimuli moves, they watching TV and they feel dizzy, we can definitely try with the visual motion sensitivity. You can do the visual motion sensitivity test for those patients and you can plan your rehab for that treatment. So treatment is different for concussion. Treatment is different for visual motion sensitivity. Treatment is different for peripheral. Treatment is different for central. So all the vestibular impairment has a different involvement and different management. More or less, they are very similar, but they have key component that we can able to identify. Now balance. So The previous test I was telling regarding VOR. The balance test I'm telling about the VSR, vestibular spinal reflexes. Just a second. Sorry for the interruption. Let's move to the VSR, vestibular spinal reflexes. Okay, everyone, after 3 minutes, we might need to re-log in if the meeting room closes. So let's move to balance training. Lateral is a symptom for the peripheral involvement. Modified sit-sip test, where we can use the modified sit-sip test when you feel the balance is affected, whether it is peripheral, whether it is central. In geriatric population, we know when we age, our system compromise, our system declines, our vision reduce, our hearing reduce. Same way, our vestibular also compromise. So in majority geriatric population, we have vestibular hypofunction. Because of vestibular hypofunction, they are at the fall risk. They are at the very high fall risk because even proprioceptions are not giving input. Even vision is not giving input. Even vestibular is not giving input. So they are at the risk of fall. If we stimulate their vestibular, we can increase their balance. So one more scope of vestibular rehab is in geriatric population to reduce the fall risk. In USA, majority you might be aware like there are so many assisted living facilities because parents are not living with their kids